Welcome to The Explainer. Today, we're doing a clinical deep dive into the Herpes Simplex Virus, or HSV. Now, I know what you're thinking. Oh, cold sores. But this virus is one of the most common pathogens on the entire planet. And its clinical story is so much more complex and honestly, so much more dangerous than most people realize. And that gets to the heart of what we're talking about today. HSV has this incredible duality. For most people, yeah, it's a recurring annoyance they have to manage. But for a few, it can become a devastating, life-threatening neurological invader. So the question is, how? How does this incredibly common virus make that terrifying leap from being a simple nuisance to a potential killer? We're going to break it down into 6 key parts. We'll start with all the different ways it can show up clinically, then get into diagnosis, treatment, and how to control and prevent infections. After that, we'll look at the really serious complications, and then wrap it all up by applying what we've learned to a couple of clinical cases. All right, let's jump right in with clinical manifestations. This is where you first start to see just how complex HSV really is, because the spectrum of disease it can cause is, frankly, enormous. Okay, so there are 2 main types you need to know, HSV-1 and HSV-2. The classic textbook distinction is that HSV-1 causes infections around the mouth, orofacial, and HSV-2 causes anogenital infections. But, and this is a big but, that distinction is getting blurrier and blurrier. Both types can infect either location. The key thing to remember clinically, if a patient has genital herpes caused by HSV-2, they're likely to have significantly more recurrent outbreaks. So let's look at some specific syndromes. You've got herpes labialis, which is your classic cold sore. The very first time someone gets it, usually in childhood, it can be a much more severe infection called gingiva stomatitis. But the real danger in this area is herpes keratitis, an infection of the cornea. This isn't just a minor issue. It's the leading viral cause of corneal blindness on the planet. You have to treat it as an absolute ophthalmological emergency. Shifting gears to genital and systemic diseases. Herpes genitalis is the most common cause of genital ulcers in the Western world. But then there are the rarer, much more severe conditions. You have eczema herpetoticum, a widespread and frankly terrifying infection that can happen in patients who already have eczema. And then there's the big one, herpes encephalitis, a devastating infection of the central nervous system that, without immediate and aggressive treatment, is very often fatal. Okay, so given that HSV can look like so many different things, how do we actually confirm what we're dealing with? This brings us to our second topic, diagnostics and identifying this pathogen with real precision. The world of HSV diagnosis has changed a lot. It used to be all about viral cultures, but they've been almost completely replaced by something called nucleic acid amplification testing, or NAAT. You probably know it as PCR. These tests look for the viral DNA itself, making them incredibly sensitive and specific. They are the undisputed gold standard. And crucially, you can swab a lesion and a NAAT can tell you not just if it's HSV, but if it's type 1 or type 2. Serology, which looks for antibodies in the blood, is mostly just used to see if someone's been exposed in the past. And this protocol for a newborn with suspected HSV really shows you how precise we have to be. This is an incredibly high-stakes situation. To check for a systemic infection, you immediately draw blood and get cerebrospinal fluid for a NAAT test. But, and this is critical, you wait 24 to 48 hours before you take any surface swabs from the skin, eyes, or mouth. Why? Because you have to avoid a false positive. That delay ensures that any virus you find is from a true infection in the baby, not just contamination from the mother's birth canal during delivery. Once you have that diagnosis, it's time for treatment. But here's the thing you have to understand right up front. Our current antiviral drugs manage the virus, they suppress outbreaks, but they do not get rid of it. They don't cure it. For most adults with anogenital herpes who are otherwise healthy, valacyclovir is a standard of care. We just adjust the dosing based on the situation. You get a longer course for a first-time infection, a shorter course for recurrent episodes, and for people with really frequent outbreaks, a daily low dose to keep the virus suppressed. It's like having a terrible house guest you can't evict, but you can at least make them stay quietly in their room. In those very rare cases where the virus becomes resistant, we have to bring out IV drugs like foscarnet. But for those really severe, life-threatening infections, everything changes. The strategy gets way more aggressive, and we go straight to intravenous acyclovir. For herpes encephalitis, that means a high dose for 2 to 3 weeks. For a newborn, it means a very precise dose based on their weight, also for up to 3 weeks. In these scenarios, the stakes are just way too high to mess around.
If there is one number I want you to burn into your brain from this whole explainer, it is this: 10 milligrams per kilogram, intravenously, 3 times a day. If you have a patient with suspected herpes encephalitis, you start this dose of acyclovir immediately. You don't wait for confirmation. Any hesitation could be the difference between recovery, permanent brain damage, or even death. This is a true medical emergency.
The fact that we can't cure HSV naturally leads us to our next topic: prevention. Since there's no cure and no vaccine, stopping it from spreading is absolutely paramount.
So an interesting detail is that in many places, HSV isn't a disease that doctors are required to report to public health authorities. That puts a huge burden on education and clinical practice to prevent its spread. This means counseling patients to avoid any direct contact with lesions. No kissing, no sharing forks when you have a cold sore. It means explaining that condoms help, but they don't completely eliminate the risk of transmission. And for those of us in healthcare, the rules are very strict. If you have an active cold sore, you must wear a mask when you're caring for newborns or immunocompromised patients. And if you have a herpetic whitlow, that's an HSV infection on the finger, you have to avoid direct patient care entirely.
And this brings us to the why. Why are we so careful? Why is prompt diagnosis and treatment so important? Well, because of the serious and sometimes permanent complications of HSV. The list of potential complications is sobering. Genital HSV can lead to neurological issues, like aseptic meningitis. In the eye, recurrent infections can cause irreversible blindness. And for newborns and the immunocompromised, the biggest fear is disseminated disease, where the virus spreads through the body, affecting multiple organs. It carries a very high mortality rate. This potential for disaster is exactly why this common virus demands our most serious clinical attention. Okay, we've covered a ton of theory. Now for our last section, let's put it all into practice and see how this knowledge applies in the real world with 2 quick clinical cases. Okay, case number 1. A 35-year-old man comes in with a painful cluster of little blisters on his lip. He says this has happened before. So what's the diagnosis and what's the typical treatment? This is a textbook case of recurrent herpes labialis. The key to managing it effectively isn't just knowing the drug. It's about timing. Starting an oral antiviral like valacyclovir, the moment you feel those first telltale signs, the tingling, the itching, can dramatically shorten the outbreak and make it much less severe. Now for a much higher stakes case. A newborn has suspicious-looking lesions on their skin. What specific samples do you need to collect to confirm if it's HSV? And how do you make sure you're not just picking up virus from the mom? And the answer, of course, is that critical 2-stage protocol we talked about. You immediately get blood and CSF to check for a systemic infection. Then you wait 24 to 48 hours before you swab the surfaces to rule out that contamination from the birth canal. It's a perfect example of how applying this knowledge with absolute precision is essential for getting the right diagnosis. This quote absolutely nails the central challenge of HSV, which is something called viral latency. See, after that first infection, your body doesn't actually clear the virus. It's not gone. Instead, the virus retreats. It travels up sensory nerves and sets up a permanent, lifelong camp in the nerve ganglia. It just sits there, completely dormant. It becomes a silent, biological sleeper agent, waiting for a trigger, like stress, illness, even sunlight, to reactivate, travel back down that same nerve, and cause another outbreak.
And that latency, that ability to hide, is the whole problem. Our current drugs are fantastic at fighting the virus when it's active and replicating, but they're completely powerless against the dormant virus hiding in the nerve cells. So that leaves us with the final, multi-billion-dollar question. What's the next big breakthrough going to be? How do we finally defeat the sleeper agent? Will it be a therapeutic vaccine that supercharges our immune system to keep it dormant forever? Or will we finally develop a drug that can go into the ganglia and truly eradicate it for good? That is the real frontier in the fight against HSV.